So let's talk about consultation structure. Me and Shiraz have come together to try and make this as relevant for this domain as possible. So after the golden minute, we want to consider asking your eyes questions of the impact on life, and I would certainly recommend asking this question about how you are coping. It's best to, and again, this was reiterated by Dr. Jamie Green when he gave us a talk on the SCA. Do look at that because it's got a fantastic range of tips and tricks and ways to prepare from Associate Dean from Nottingham, I do believe. An amazing webinar that'll teach you a lot about how to consult. And he says it's very best to naturally integrate this into the consultation rather than making it too robotic. And of course, we would want our GPs to be actively listening to us. And actively listening is a bit different from listening. And again, something that Jamie taught me. Listening, of course, is something we do day in and day out. Active listening is where you're able to put aside all your subconscious bias, all your preconceived notions of the patient in front of you, and try and get a pure understanding of what their issues are, what circumstances they've come from, and what you want to do to help them that's individualized for this person in front of you. Next, I think it's really important to cover things like red flags, particularly safeguarding, same-day admissions, and that can include cases such as, professional conversations, etc. The history of the presenting complaint is really, really important. We talked in the mental health webinar, and when Shiraz has done his talk before, after he passed the RCA, the squitarps is a mnemonic that he used, so have a look at that webinar. And again, I think we briefly went through it as well during the gender and reproductive health webinar. Again, the Socrates and mental health, Duke, the consultant psychiatrist, came up with a great way to use Socrates in mental health examination that isn't related to pain whatsoever. So have a look at that if you haven't already. And again, all of these things are transferable skills across the domains. Us as generalists, it's really important for us to take little bits from every specialty, if you will, and then integrate it all together. Sometimes we're juggling multiple cognitive processes at the same time, multiple problems, multiple issues, but we just get stronger the more we practice, the more we are familiar with these sort of situations. The past medical history is really important, including any associated symptoms and conditions and differentials you want to consider. Current medication, of course, is very relevant. And smoking, social history, including smoking, alcohol, drugs, occupation, relationships, finances, and support at home is really, really relevant to this cohort in this particular domain. Again, management, we're aiming to start at the 6 minutes mark, so halfway through, and tailor your management according to the patient's ideas, concerns, and expectations. Offer an examination, very, very relevant. You're practicing ideally in, a practice that's virtual, but has all the resources available to you as a trainee. So don't worry about your local issues. Think about what is best for the patient as per national guidelines. If it's available anywhere in the country, you are able to use that resource and signpost towards it. Again, think about your questionnaires and diaries, so your peak flow diary, for example, your pain diary for someone with chronic pain. Maybe there are other diaries that you want to use, and you want to send them other resources as well that's really relevant to empower your patient. And I would strongly recommend, resources from societies or from patient.uk, and it's just UK is great for explanations of conditions as well. So think about using all of those resources to empower your patient as much as possible. And then we move on to investigations, referral, non-pharmacological interventions, and lastly, medication. So I purposefully put it in that order because you should be thinking about all of these things before you prescribe the medications. When we are more junior, of course, we think of medicine as very didactic, almost a bit of paternalism, if you will, where we throw medicines at a situation, and if it doesn't work, the patient comes back, and if you don't hear from the patient again, then clearly the medicine has worked, right? Whereas now we realize that there's a biopsychosocial model that we should be applying to all conditions, and recognizing how other forms of support might tie in, other ways in which non-conservative measures can be utilized is really, really relevant here as well.